gonna get started. Next up, we have Dr. Michael Garrett. Dr. Michael Garrett is Professor Emeritus of Psychiatry at SUNY Downstate, widely respected for integrating trauma-informed psychodynamic and cognitive approaches in psychosis treatment. Please welcome Dr. Michael Garrett.
I got to the platform without tripping, so it's that's a good start. Can everyone hear me okay? Yeah, okay. It's been such a pleasure to be at the conference to meet people of like minds and spirits and hear about all these different points of view. I was telling Ross, I think that I've learned a lot, but also I think I've had some thoughts about how I may be a bit different than some of other people, and I think that's partly because of my background as a physician. And I really don't want to be melodramatic about this. The Pope has not nominated me for martyrdom, or my name isn't even on the the distant list. But in medical training, I was a young psychiatrist. And you do overnight call, so you can get called to the medical wards. So I got called one night, awakened from sleep about 1 in the morning. So I go up to the gastrointestinal intervention unit, and we were talking about choking up during presentations, so do the best I can. So I go up there, and there's a man bleeding to death on a gurney. A psychotic man who refuses to give permission to the interventional gastroenterologist to scope him. And he has esophageal varices, which is because he had cirrhosis, and he has these, he's slowly bleeding to death, and the floor is covered with blood. I'm not going to get through it. I had 10 minutes to talk to him and try to convince him to sign the form. And then you're just working. Oh, this is ridiculous. I should not have started with this story. No, but I'm proud to this day because you have instincts, from your training. So nobody taught me, well, yeah, if you have a guy bleeding to death, you follow this protocol and, do this kind of thing. There is something instinctive about engaging with the man, and I think that connects with what many of you have been talking about, some kind of real space of connection with people, because the gastroenterologists, they weren't going to do anything. They were going to let him bleed to death because they didn't have permission, to do the procedure. So I convinced him. We had a dialogue. We had a conversation, and it had to be a quick one. And he signed the form. So back to sort of style of working. I think that I may be a little more get in there and do something, kind of clinician. And those of us that work in the city hospital system, there's a lot of pressure and a lot of patients, and you can't say, we don't have an opening now, and we can see you next week or something like that, because there's folks waiting. One other funny, I think it was funny, I idealize Gould Farm, and Nancy and I had a lovely tour here. So I'm walking around, and I'm walking in the back and looking at the bathrooms, and I think, oh my God, Gould Farm is so enlightened. There are 3 bathrooms for women and none for men. Isn't that a reverse? How refreshing. But then oh no, I misread the icon. I thought it was a skirt blowing to the side, blowing to the side with the Berkshire winds, No, it's an icon of equality. So, okay, that's good. All right, let's get serious. Okay. So, what I'm going to talk about today is the relationship between trauma and psychotic symptoms. And I'll finish up with a clinical example that illustrates this. And Freud was a bright boy. And he anticipated many things that now, in the second time around, are coming back again as kinds of understandings and insights about things, including in neurology. So he wrote a paper in 1986 about Frau K. And in this paper, brilliant paper because it's all his instincts, a woman who had been sexually abused by her brother had a psychotic illness, and he talked for the first time about mechanisms of projection, ideas of reference, and so forth. So it's a very insightful clinical paper. And after that comes studies in hysteria, where Freud and Breuer say that hysterics suffer chiefly from reminiscences. So what I'm going to talk about, it's the same. It's the same with people who suffer psychosis, only the form of the reminiscence is different than, but it's still a reminiscence of one's sorrows. Okay. I won't spend a lot of time on this, but this is the history of DSM diagnosis of schizophrenia. And it's changed over the years. So it started off with Emil Kraepelin with a very biological base, basically a dementia precox, meaning a premature dementia, all organic, and the person's brain is deteriorating. Then, not too many years later, with Eugen Bleuler, he says, no, this isn't a discrete illness, this is a syndrome of things, and you can discern what he called idea complexes. And this was the beginning of the formulation of psychological constellations of ideas that had powerful influences on people's lives and feelings. Then we have Kurt Schneider, who introduced the idea of first-rank symptoms of schizophrenia. And I think psychiatry was struggling for how do we diagnose this? How do we nail this down? So even though Schneider didn't present it this way, the psychiatric community seized on first-rank symptoms, and the idea is, well, if somebody has one of these symptoms, then they're schizophrenic by definition. But it didn't hold, because all of these things are decided by committees. They're not decided by evidence or patient. So the committees change and the ideas change. So then from DSM-2 to DSM-4, by DSM-4, the Schneiderian first-rank symptoms are in real prominence, but then by DSM-5, Schneider is fading. So it's a work in progress, and we'll see what DSM-6 comes up with. All right. Because some of you may not be so familiar with the medical and genetic side of things, I'm here to tell you that schizophrenia is not simply a genetically determined brain disease. And there's a great deal of evidence that it isn't. However, that's not to say that biological factors don't play a very important part in the disorder. And the way I've come to think about it is that PTSD, by definition, is a trauma-related disorder, and the phenotype of expression of the traumatic reaction is a certain characteristic sort, so we all recognize it. And in that case, the trauma trace is horizontally repressed, but then surges back and takes over the mind, and then it's repressed, and then it surges back. That's the phenotypic structure of the trauma trace in PTSD. In DID, there's a vertical split. So different alters carry part of the trauma, and they're not co-conscious. The splits in psychosis are both vertical and horizontal. And I think it's biology that conditions the kinds of splits that are possible under those circumstances, but the driver of all of it is one's sorrows. And the sorrows are not necessarily sexual abuse or physical abuse, but much more idiosyncratic, bad luck, symbolic kind of things that back people into developmental corners over a period of many years. So here's some facts about schizophrenia. There's no pathognomonic sign or symptom or biological marker of schizophrenia that's ever been identified as an independent validator of schizophrenia. This is amazing. How can that be? A condition that affects and disables 1% of the population, and there's no biological marker of it? That's got to be a clue, you know? That's got to be a clue that it's much more distributed in the personality of the person. It's in their lived experience. Sir Robin Murray, who's become a little hero of mine, never met the man, but you can tell from the Sir that he's an important guy. He was made a lot of very good contributions. He's a British schizophrenia researcher, and he wrote a paper in 2017, Mistakes I Have Made in My Research Career. And in this paper, he says this guy is like the authority on biological approaches to schizophrenia, that he expects the term schizophrenia to disappear from the literature, and that it will become a kind of old-timey word like dropsy, you know, when people didn't really know what was going on. And he says that the idea that it's an independent entity, in his words, have been fatally undermined. And what courage would it take for a man like this who's built his career on this idea to openly acknowledge it and publish it? The genetics of schizophrenia are in now. So 50 years ago, people were looking for the schizophrenia gene. There is no schizophrenia gene, and if there was, it would have been found by now. What there are is genes that have a very small influence on the development of psychosis. One is the 22q copy number variant. If you have that mutation, there's a 1 in 4 chance that you will develop a psychotic illness. That's biology there. But what percentage of the population has that? Less than 1%. So it doesn't explain very much about you know, the wide range of folks that, you know, come to that issue. The next thing that the geneticists tried to do is say, okay, all right, there's no single gene, but maybe there are clusters, you know, of genes, and maybe if we get the right clusters, then, you know, we'll get the numbers higher. So the TCF4 gene, that's at the top of the cluster list now, and that polygenic set only gets you up to 0.6% of the variants. We could go on with this, and you know what the next step of the geneticist is? We now have omnigenic, explanations where trying to get a cluster of, you know, hundreds of genes, and it's ridiculous. Well, okay, there you have a person, you know. That's not a genetic, you know, illness. 15% of the general public report trauma versus 50 to 80% of people who have a history of psychosis. So the numbers of abuse are very high in folks that end up psychotic. And it's a kind of common sense thing to say that relational trauma, which is the most common result, requires a relational solution. And that's what everybody is, you know, here about, believes in that. And the idea that you could give somebody Zyprexa and that's going to fix, you know, a childhood of terror is just an absurd, really absurd idea. Okay. I will probably fail to manage my time correctly, but there are now lots of review papers on the incidence of childhood trauma and psychosis. And this is one of the older ones, and there was a recent one just published in the American Journal of Psychiatry. And the numbers are pretty consistent in all these meta-reviews that the risk ratio goes up about 2.8 if you have a history of child abuse. And there are some particular kinds of abuse where the number skyrockets far beyond any genetic influence. So if a person has had a traumatizing rape and they also have phenomenologically psychosis and PTSD symptoms, the incidence of florid psychosis goes to 18-fold. This is a huge number. It's much higher than any genetic gene cluster that's been identified. And there's a dose effect. So the correlation doesn't prove causality, but in this study where there are 1 or 2 traumas, the risk ratio goes up to about 2.5. But if there were 5 or more traumas, these are people that have had nightmares, nightmarish childhoods, the risk ratio goes up about 10-fold. So the relationship to trauma is dose-related, which is a strong indication of causality. Oftentimes, in the medical literature, we hear discussion of how PTSD is comorbid with schizophrenia, which also is another silly idea. It's not just that, oh God, what bad luck, that have 2 of these trauma-related disorders, oh God. No, it's not that way. It's part of a complex trauma reaction syndrome where some people manifest it in slightly different ways. And an example or a comparison that I find funny, probably all of you have had the experience of having a trauma reaction to a splinter in your hand. And sometimes the splinter, you get a lot of swelling and a little bit of redness, but not much temperature. And there are other times you have some kind of injury and you're running a little fever and you've got pain and a lot of redness. So in medical school, we learn the classic 3 indications of infection. And they are? You didn't see that coming. Okay. They are rubor, meaning redness, the infection's red. They are dolor, pain, and they are calor, temperature. So imagine if doctors said, oh, Ross, you got it bad. You got 3 comorbidities. You got rubor, calor, and dolor. And it's piling up. You've got 3 conditions. That's what medical psychiatry is doing, with this complex PTSD trauma reaction. And it's immediately silly to talk about a calor, rubor, and dolor being comorbidities. So it's a systemic reaction. It's the body, the mind trying to come to some kind of equilibrium. So, put it simply, painful things happening to you is the primary instigator of psychological suffering, symptoms. And while biological genetics play a role in the phenotype of the trauma-related disorder, it's not the cause of it. It's not the primary driver. And I think in the Ellenhorn presentation, the same question was posed, actually. I'd made my slides up before I... So I'm confirming the idea. The question is not what's the matter with you, but what happened to you? What's your story? I won't dwell on this slide, but would like to recommend this book, General Psychopathology. Very interesting, authoritative book written by Carl Jaspers, who started out his life as a psychiatrist by age like 32, wrote a brilliant book, and then went on to be a philosopher. The guy really had a lot to say. And he makes a very important distinction, and now I'm going to become a little more sympathetic to psychiatrists, being one. There's a distinction between what Jaspers called erklären, which is a way of explaining the world, not empathically understanding it, but explaining it, and another way of knowing people, which is verstehen. And this is the human empathic way of knowing the person. And there's power in both of them. So DSM is an erklären document. The claim of DSM is if people have these characteristics, you put them in a group, then you know something about them. And you do. You know a little bit about them. And the main distinction, I think, that psychiatrists make, and it's a very important distinction, is will the pharmacy of mood stabilizers help this person or not? And diagnosis helps to make that decision, and then you make the decision, and then you see what happens. So knowing the patient as an object, as a diagnostic object, cannot be avoided in medical practice. But what happens is that psychiatrists, because they're so busy and because they're not taught, they're not evil people, for the most part. No, I was thinking of one guy in particular. But no, they're just uninformed. They haven't been taught. They don't understand it. They're afraid of their minds. They're afraid of their experience. They're afraid they're going to be swept into the undertow of the chaos of the psychosis. And so they are taught and stick with the diagnosis because that's enough to make a guess about what you're going to prescribe, but it doesn't take you anywhere, really, in understanding the personal subjectivity of the person. I was telling Nancy about this slide, and I'm hoping it will add something, or maybe it's just me playing with an adult video game here or something, but I want to talk about levels of explanation. And one of the things that I think biologically committed people who can't see the psychology of things, they try to outflank you, by saying, well, it's all the brain, right? It's all dopamine, it's all molecules and so forth. Yeah, it is, but when you think about it, there would be no conception of dopamine without a mind. There'd be no conception of the content of psychotic symptoms without a spirit. So actually, the superordinate structure is the mind and not biology. And the conception of dopamine is, if you look at that from the point of view of quantum mechanics, there's no molecule there anymore. You look and then it's gone. The Heisenberg uncertainty principles, it's blown the certainty away. So the question is, at what level of explanation do you sample the person's experience in order to try to be helpful to them? And in some cases, you want to sample at the biological level to do something, but now let's see if this slide works. If we start with the idea of understanding someone at a behavioral level, an abused child doesn't trust adults. Okay, this is something we can determine, observe, and it doesn't require us to know how that's represented in the brain. It's just, we know it, certainly. And then we can say anxiety causes an increased heart rate. So we're moving deeper and deeper into the body here. You can measure that anxiety causes an increased heart rate. Then, in the case of psychosis, when dopamine binds a D2 receptor, it increases the salience of perceptions. This is demonstrated in the research also, and this is where you get ideas of reference on the basis of the experience of hypersalience of events, and then people project meaning into these events. Now, you remember what was on the slide before? There was a face. It's a person. They're gone. You're left with the molecule. And at the level of the molecule, what is the causality? It's disappeared. You're just seeing, these tinker toys, bouncing around. This is a meaningless realm of human experience. It explains nothing about. It's not the language to be talking about life experience and what people go through. All right, trying to define trauma. In order to do research, you have to have an objective scale and measure certain fairly dramatic features in a person's life. But it's the meaning of the event and not the event itself that creates the trauma. An example of that, Kirkpatrick reported the case of a woman who was raped and did not develop PTSD. Then she found out a couple of weeks later when they caught the perpetrator, she found out that man had murdered 2 other women, and she realized, oh my God, I could have been murdered. That's when she got PTSD, because the meaning of the experience changed. So it's always the meaning of experience that creates the trauma, and from a psychological point of view, it's the incapacity of the mind to make sense of it, to bind it, to make it into a coherent, integrative part of their previous representation of themselves, and in the case of moral depravity and war, they're representation of the world. So there are lots of Vietnam vets who went to war believing in God and believing that this was a Christian mission, and they came home atheists. They couldn't integrate the experiences that they went through with their mental representation of a Christian world. So the dramatic things that can be measured on trauma scales are what I think, if you ask the question and the patient honestly answers it, then you can check off, okay, the person has a history of trauma. But you actually have to get to know a person a bit more to understand other forms of trauma, which are not the blunt trauma of brutal life experiences, but much more subtle things. There's symbolic trauma, and then there's what in the analytic literature is called strain trauma or cumulative trauma, which is that the same thing happens over and over and over again until the mind can't bear it anymore, and then there's a falling apart. And this is the kind of trauma that happens in families where parents, with goodwill toward their kids, are determined to see their children in a way that they aren't. So the kid has no chance to find themselves authentically. So they get into a prison of being a false self, and they can't live that way forever. And then they break down, and the psychosis is a scream for some kind of authentic living. So you have to actually get to know people pretty well before you could see, oh, that's how that worked, and that's how that became a trauma, for you. There are reasons that trauma lingers, and so I'm just making this up, but I hope this makes sense to you. One is that there's a biological necessity for remembering adversity, because any organism that forgets about the bad stuff that happens to you will not survive in evolution. And so we have to remember bad stuff in order to avoid it in the future. But there's also a psychological necessity for remembering. And the authenticity of our identity requires our remembering the bad things that had happened to us. Our history is our identity. And a life history that excludes our sorrows is an inauthentic story. And people don't want to go to their graves having lived a lie. So I've never seen an epitaph that reads, "Oh, what a relief, I'm gone now." I got through my whole life and I never had to live authentically. I made it to the finish line, always a false self. No, there's a deep drive to live in a real way, to live authentically. And that's part of the necessity of remembering one's sorrows. The other thing is that you have to remember your sorrows before you can speak to somebody else about it. If you can't remember what happened to you, you can't have a conversation with somebody. You can't have a dialogue with somebody about what happened to you. So authentic living requires a witness to affirm the reality of one's experience, and attachments to others is the primary source of comfort. But we can't access that comfort if you can't recall the trauma and speak about it. So abused children, they can't speak about their trauma. They don't have the language. They don't have a way to do it. And their only way of speaking about it when they become psychotic adolescents or adults is a dramatic enactment of their trauma in the form of disguised reminiscences of the trauma, which are embedded in psychotic symptoms. So the patients are trying to say, listen to me, listen to me, but they can't make a clear, coherent, conversation about what ails them. And a biologically oriented psychiatrist just writes it off as confusing nonsense. There's no message here. It's all chaos. I will just show you this. Mainly just note how many different kinds of memory there are. There are 11, so there's a lot. And the idea is that ordinary memory is modular in all of us. So the thing that most of us call memory is what's called declarative episodic memory, which is, I remember, it has a time and place signature. I remember I was at Gould Farm. I got up the stage without tripping. It's an episodic memory, and it's consciously available, and you can call it up. This is the most fragile form of memory, and there are other forms of memory which are not consciously declarable that are much more accurate and much more enduring, and those include the implicit relational knowing that happens in the first year of life, the dance that develops between the mother and the infant. So some kids realize that when they're upset and they cry, their mother comes to them. Other kids realize that their mothers are anxious with them. They don't put it in these words, but the mother perceives the dependent needs of the child as a danger to them, and they pull away. And those kids learn to go underground. So a relational dance begins before there's any language, and that's the first imprint, the first template to the relationship to others. There's internal object-related fantasy, which is present by age 18 months. There are semantic memories of things, where a semantic memory is episodic experience happens, and then you generalize it, and you think you know a fact about the world. And that's what a delusion is. It's a particular kind of semantic memory that tries to make sense of an incomprehensible situation. There's sensory memory. And this is part of Van der Kolk's the body keeps the score in the case of trauma. And there's solid research on this. Brewen has identified what he calls S-reps and C-reps, two different kinds of memory constructions in PTSD. And what an S-rep is, it's a sensory memory of the experience. And a C-rep is a conceptual memory of what happened. And you can guess what dominates in PTSD. It's the S-rep. The flashback is a flood of sensory experience, and it's split off from a categorical explanation of why did that happen to me? Why did my father abuse me? Why did my mother abuse me? Which can't be put into words. There's also emotional memory, somatic memory, gist memory, context memory, associational and priming memory, and non-declarative implicit memory. And I'm going to illustrate these with some clinical material. So, to tie together psychotic symptoms with memory, persons suffering from a paranoid psychosis typically believe that their suffering is caused by a persecutor that's located outside themselves in the real world. And they don't generally believe that their problems arise from memories of real traumatic experiences that occurred in the past that are distorting their present experience. And biological clinicians don't recognize psychotic symptoms as memories, as distorted memories. Here's some examples. I mentioned before Breuer and Freud and their conclusion that hysterics suffer mainly from reminiscences, and then the case of Frau P, where Freud did some really seminal intuitive thinking about psychosis. And let me tell you the case of little Betsy, okay? This is an extraordinary case in the analytic literature. A little girl who had a loving family, loving school, all the support you could hope for a child. And she suffered a horrible trauma. She was out in the park one day with her nanny. She's 10 months old, and a deranged man comes over and stabs her in the abdomen. And only the quick thinking of the nanny got her to the hospital. And here's another choke-up moment. The word on the street is that the pediatric surgeon that saved her life kept a picture of her on his desk. So she had a massive wound, and that resulted in a large abdominal scar. So she recovered from all of that. Age 3, she's helping her father in the kitchen, and she's leaning over against the kitchen, and she's, "Daddy, my line hurts." So she's talking about the sensitivity of the scar, and then she reflects and she says, "That was a very bad day." She has a somatic memory of the trauma, and she has an emotional memory of the trauma, but she can't articulate what happened. A year and a half later, when Betsy's about to go to school, the parents didn't want some wise-ass kid telling her what happened, because this is something that had been in the local papers. So they met with Dr. Coates, the analyst who was working with Betsy, and the school and the parents, and they developed a plan together about what to say. So the parents told her, what had happened, that there was a bad man who hurt you, and he's no longer here, you're safe, and nothing's going to happen to you. So then Betsy begins to metabolize this and goes into a semantic elaboration of it. And this is what a delusion is. It's a semantic elaboration of a sorrow. So she said, oh, yes, now I remember. I was in the hospital. She remembered that. I was in the hospital, but my little sister was with me the whole time. She was in the same bed with me. So she creates a memory that's a salve. She was never alone. Her sister was there. And then she says, yes, all my family was there in the room. So the memory works this way, and that's what delusions do. They try to tell a story about the person's life. That's the best they can do to make sense out of an unbearably painful and confusing kind of situation. We're not done with Betsy yet. She's 9, and she gets to go to a Halloween party. And she's developing as a normal, kid. So she goes to this Halloween party, and luck would have it that among the decorations, there's this sort of shadowy male figure who appears to be holding a knife. She had a panic attack and had to leave the party. So what we see here, speaking about it in terms of memory, is that her associational memory and the priming in her memory system had highlighted men with knives, so that was a pretty close approximation. But you can imagine symbolic representations of a man with a knife that would also trigger the same network. And that's what happens in the precipitant of psychotic episodes, where it's like a Richter scale 10 resonance with some traumatic event that pushes a person over the edge when they're teetering at some developmental place that they can't accomplish. Here's some other examples. Bert Karen, who passed away a couple of years ago, who really carried the torch for psychotherapy for psychosis for several years, he describes a patient, a man who was institutionalized in psychiatric hospital for 10 years, who was prone to unprovoked violence against people in the hospital. He'd creep up behind other patients and choke them and lift them up off the ground. And then, when they were trying to gasp for air, he would drop them, so he never killed anybody. So the psychiatric residents, he was doing a conference for them, and he said, he would come on the ward and interview a patient. So they wanted to give him not an easy case. Give him that guy. Give him that guy. But Karen had a gift for connecting to people. And in one session, he elicited the memory that his mother used to punish him for not finishing his dinner by putting a cloth around his neck and choking him. And the evidence that those two things are connected is the effect. After that intervention, he stopped choking people on the ward because the behavioral memory had been made conscious, and he was able to metabolize it and absorb it in a different way, where Karen was with him, with the memory, sharing the memory, eliciting the memory. Okay. In the interest of time, because I'm going to leave some time for discussion, there's a rich research now. I'd say there are probably 22 papers published where different methodologies that demonstrate that many psychotic symptoms actually contain direct representations of traumatic memories. They tend to be, in the CBT literature, they're called decontextualized, so that when a person hears the voice of their rapist, only an idiot would say, well, that's just biological chance. No, of course not. This is a fragment of a memory that's dissociated from its episodic context. So in the Hardy case, for example, and all of these are good studies, she studied 75 participants who had a history of psychosis, who heard voices, and she was able to determine that, or her group, 12% had similar themes and content to the trauma, and 45%, the themes were the same, but not exactly the content. And the other 45, I would warrant, let any of us in the room and give us a couple weeks with the patient. We'll see what the trauma was with those folks too. But this is the best they could do just on one cross-sectional research examination defining the trauma. So the incidence of trauma is vastly underestimated because it takes a while, for people to open up about it. And another way to say this is that people feel in the presence of their trauma as they must, because there's no mechanism for them to entirely forget it. They feel in the presence of their trauma when they are living an allegorical story that mirrors their life experience. And that's the level of disguise. I was working with one of the psychiatric residents. The patient had a history of sexual abuse, and the resident was, I wouldn't call this one of the three poisons, but the good-naturedness of the resident trying to do what they're supposed to do, inquire about trauma. So, the patient says, yes, I was abused as a child, but I'm over that now. I don't really want to talk about that anymore. So the resident said, well, what would you like to talk about? And she said, well, my neighbor, he comes into my house every night, drugs me, rapes me, and then he slips out in the morning. So this person thinks about nothing else but her trauma, but she thinks about it in disguised form. It's displaced onto the neighbor because she can't connect it with her own, actual life experience. Okay. Now, this may be a new concept for some of you, but I want to talk about the ideas of Carl Friston and Mark Solms and others in the neuropsychoanalytic movement and group. And you all know that your bodies are a self-organizing system where there are homeostatic regulatory mechanisms, so that if you run up a flight of stairs, you breathe faster because your pH has gone down and you have to blow off some of the CO2. Or if the temperature has to be maintained within a couple of degrees in order to maintain health. Otherwise, human cells break down. So there's a complicated system of equilibrium that maintains living organisms. Now, if we had more time, I'd be happy to get into the spirituality of this, but it's my personal belief that we are all spirit beings. And I don't even quite know what that means, but we're all spirit beings, and that we have a regulatory system that regulates our spirit, and it's monitored by affect. It's not monitored by cognition. So that when we get upset about something, the alarm's going off, temperature's going up, it's swinging out, and then it swings back, largely through defense mechanisms. And those can include avoidance or the whole complicated, creative array of defenses that people use to not engage what's deflecting the needle. And that's what a delusion is. The person rewrites their life in a way that brings the needle back, not all the way to a comfortable zone, but better than the unbearable thing of remaining the particulars of what actually happened to them. So the mind is a self-organizing system. And unlike cognitive behavioral therapists who think that the reason that psychotic people persist in their delusions is that they have a deficit in what's calling belief updating. So it's a postulation that there's something missing in the brain. I think it's not like that at all. There's something desperately in place to maintain this delicate homeostasis in a place where the person can live, because if it goes too far, that's suicide or catatonia, and that's a complete inability to be in the world. All right. Tell you about a case to illustrate how psychotic symptoms are represented in contain elements of trauma. So Maya was in psychotherapy that I supervised was a middle daughter born to parents of a diplomatic corps, and owing to her parents' international assignments, she had a chaotic childhood where she was constantly changing schools, very insecure attachments. She reported in the interviews that when she was little, that her father used to come to her bedroom at night and touch her privates. And when she told her mother about the molestation, her mother called her a wicked girl for making up such stories. She then told her clinician that she dropped out of college to pursue a more important goal. She was working with the president and the first lady to expose a pedophile ring in town. She lived in a constant state of fear, but was nevertheless determined to bring the pedophiles to justice. She claimed to have a sixth sense that allowed her to identify the abusers. Her job was to watch and report telepathically back to the White House if there was pedophile activity in her neighborhood. She also interpreted ambulance sirens in the area as warnings sent by the White House that pedophiles were nearby. And at night she heard a derisive voice calling her a slut, and she occasionally heard footsteps in the hallway that she thought indicated that an intruder had come into the house. And she sometimes awoke with a telltale sensation in her genitals indicating that she'd been drugged and raped as she slept. And neuroleptics marginally allayed her fears and during the day, but they had no impact on this psychotic constellation. So I would say only somebody who's willfully blind will fail to see the connection between these psychotic symptoms as fragmented memories of the trauma. The footsteps in the hall are her father's footsteps as the father is coming to the room. The genital sensations are his touch, the abuse. The president and the first lady, let's do this together. Who are they? The idealized parents that she never had who are finally doing something, who are on her side. She builds her dignity and determination around this delusional role. And the idea that it would be an aim of a psychiatrist to deprive her of this when you have nothing else to offer is, malpractice is too quiet a word. Okay. So let me tell you a personal story, and then there'll be some time for questions. Since this is supposed to be I'm looking at Gabe. This is like meet the author, thing. Okay, yeah. So I can mention my book. One of the premises of the book is that Psychosis, the content of Psychosis, it's an autobiographical play that's staged, not on Broadway, but it's staged in the real world, in the person's neighborhood, and with the neighbor, with people across the street, and that the characters in the play are all projections of the patient's mind. So there appear to be, usually not hundreds of characters, there's usually only 2, 3, or 4 characters, but they're all fragmented projections of one mind, the patient's mind. So it's a play. And essentially what biological psychiatrists do is the patient's enacting a desperate play. And have any of you been in a theater, you're watching a play, and somebody in the audience shouts up to the stage, "This is ridiculous, you're all actors, You're not really, Richard III, this is a sham, you're gonna go out and get in your cars, after this." No. They understand it's a performance. It's a performance that has a human meaning to it. So, do psychotic patients really create autobiographical plays without knowing, that they're doing it? Here's an example from my own experience. I've never had a florid psychotic experience, but I've had 2 experiences in my life where I felt very unsteady because of things that had happened to me. I mean, I was holding on to the podium, but those were very useful learning experiences to me, to do this kind of work. And so when I was in college, I went to Amherst, not too far from here. All right, shout out to Amherst. So I was never physically or sexually abused, but my parents were very absorbed with each other, and they really had no fun with the three of us, with me, my brother, and my sister. So we were, well fed and taken care of, and so forth. And actually, I've come to think more kindly of my father as the years have gone by, but was kind of a lonely, growing up. So I went to college feeling like the outsider guy. And I'm going to this place where, Jesus, a third of the guys here went to prep school, Andover, I heard of that place, Hotchkiss. So I paired up with this guy, Frank, and we were doing this was the 60s, some guerrilla theater, and, fooling around, college humor. So a typical thing that we would do is Frank would play the fraternity guy, the cool guy. Everybody wanted to be him, the guy who would decide whether you could get into the best fraternity or not. And I played the outsider guy, and we had different views of this. So the usual progression of it was I would notice that Frank was paying attention. Oh, he's looking at me, and then I would do something, like strum a few things. Everybody played the guitar in the 60s. You couldn't date if you didn't play. Strum a few things, he's interested. He's good. So he comes over, and all these plays, I didn't understand the meaning of it at the time. All these plays ended up with betrayal. Betrayal that was so shocking that it was like an Andy Kaufman humor. It's like, oh my God, how did that happen? How did he become so cruel, to him? It was just shocking. So I was enacting an autobiographical play, writing the play with Frank. I had no idea I was writing a play, and only in my analysis did I understand why I wrote that play and why those characters came out that way. So if I can do it, psychotic folks can do it also, because they have greater imperative. All right, time for some thoughts and questions. Yes?
I just want to say to you that as I was listening to you, I had this profound envy of presidents that are in your program. Just wishing I had anybody to teach me this 20 years ago. Now, I work at the Austin Rick Center. We think about such things all the time. But I just want to say I'm grateful to listen to the way you put it and the way you think about it, and the fact that you're trying to teach young psychiatrists and things like that. That needs to happen everywhere. So thank you.
It does, and I got a 5-year plan, which probably won't work out, but residents have told me after they've learned something about the psychology of psychosis, and actually working with Jane and the Erickson Institute, there's an hour-long video, very moving, of these residents speaking about their experience of learning about the psychology of psychosis. And one psychiatrist says, it's shocking, I could have graduated without knowing any of this, thinking they would have gone into the world blind, to some fundamental things. So it's a real problem in education, and we're all doing what we can, within our area. So I'm a public psychiatry, psychiatric residency grounded person. And so I'm doing what I can over in my area, and all of you are doing what you can, in your arena of practice. So thank you. So. Yep.
There's dangers in the other direction too, and I really appreciate that you brought in this story at the beginning about saving that guy. That in the direction of kind of the open dialogue orientation, the dangers in therapeutic nihilism, right? Do nothing. Don't do something. Sit there.
Right.
And there's real problems with that. And I appreciated you beginning this thing by kind of ending the day with reminding ourselves of that. That we're here to help people. We're here to step in on some level.
But the usual atmosphere in hospitals is what you all guard against, which is the diagnostic reduction of people to a diagnosis. So it's not a 50-50 kind of thing. Mostly it's a crime, that's going on. But it is complicated because I'm part of a peer supervision group with some fairly senior psychoanalytically oriented clinicians, and I found my reaction to them, they're my colleagues, they, analytic colleagues, and I was saying, come on guys, pick up the pace, what's happened, 5 years, 5 years, and this patient can't read their medical record without completely distorting it, let's try a different path. So it's a complicated thing, and I think consultation, can help just to get a fresh voice to, are we locating this, in the right place? So I want to tell my colleagues, you're going too slow here. This is, you got to talk to this person. They're really distorting their medical record. This was a case where somebody presented a patient, and the transcript was, they went to their internist and had a completely floridly paranoid reaction to the internist's, just very sober note. So, yeah. Yes, okay. I suddenly realized I have the authority to call on people.
So when a therapist is working with a patient's trauma, it can be helpful to process the trauma and elucidate it. But I think there's also a risk in traumatizing the patient further by maybe telling them what happened to them. Even your story of little Betsy made me think, well, is there a chance that the panic attack at the Halloween party was in fact caused by her being told what happened to her? And I'm curious, how you think about when to kind of pull at someone's story of their trauma and when that might be hurting them.
You wait a long time. So I'm not talking about psychotherapy technique here. I'm talking about an overview of, like if we ask the question, how do we go from here to Albany? Well, it's kind of over there, right? But there's lots of twists and turns. So this is not a recommendation of, get to the trauma quickly. And there are some people where they made significant gains and they never have the aspiration to, nor maybe could they, fully connect with and realize the trauma. But they're buoyed up enough about the good things that are happening in the therapy that they don't have to revisit that road. So the question is, are they haunted by the trauma in a way that is really disturbing to them? And with Betsy, the time frame was that she was told at 4.5, she had the panic attack when she's 9. So the way I would read that, no, it wasn't a direct connection, but she maintained a subliminal, unconscious trauma trace. And one, I think, would make the assumption that if she was never told what happened to her, she would elaborate that in some way, and she'd be more vulnerable. So the story told by loving parents grounded that experience and anchored it in a way so that it didn't fly off into, imaginations, years ago when she was in some developmental situation. Yeah, so it's a very sensitive thing to talking to patients about trauma. Yes?
How do you think about the use of
I'm trying to be chronological with the raised hand.
How do you think about prescribing antipsychotics? I hear in a ways that it may be discounting or these ideas or covering up things that could be helpful, but also I imagine having experienced, certainly myself having experienced them as very helpful, and how to work with both of those ideas.
I think that I'm certainly not against medication. I've probably written more scripts than you. How old are you?
I'm sure you have.
Yeah. So I've written a lot of scripts, and so for some people it's life-saving, and there's very little research on this. There was an Australian group that studied trauma intrusions in psychotic patients. So it's not a broad study of symptoms, and they found a very interesting result, that for some of the patients in that group, neuroleptics were life-saving. They said, I couldn't think without the meds damping down my affect, and then I could engage in psychotherapy. I could talk about my life. There are other patients who said it didn't have any effect, on the trauma intrusions, didn't protect me at all. And there were a couple of patients who said that actually the meds made it worse, made the trauma intrusions worse. So what we're talking about here is the kind of sophisticated pharmacology that patients get at Riggs, where it's not just, write the script, and if that doesn't work, up the dose. You have to talk to the person and coordinate with whoever's doing the therapy and the patient about what are the drugs doing to your mental life, to your mental state. So it should be an integrated approach. Yeah. Her and then, I see you. Okay, go ahead.
I'm kind of hesitant to ask the question, but I'm going to ask it because it was kind of along with what she just said. But my question is, how does a patient begin to recognize that trauma might be connected to their psychotic experience or story, especially if the patient doesn't think they've experienced any trauma?
You have to wait until you wait until you see a sign. Oftentimes, for example, I can't do justice to that without, we could discuss actual patient, but most psychotic people live in a state of pervasive fear all the time. So a way that you might get at that is, am I right? You feel frightened, really frightened all the time, yes? And do you ever have a period when you feel completely safe? Well, I do better in my apartment when I'm in my apartment. That's why I don't go out very much. I feel a little bit safer there. And then the next question is, can you remember a time in your life where you felt safe, where all of this changed? And if the patient says, no, I can't remember a time in which I was safe, then you can then say in an open-ended way, I guess things felt pretty dangerous for you as far back as you can remember. And then leave it at that. And then you see, if he says, yes, that reminds me of, or the patient says, oh, not today. Point made. So that's the art of monitoring the patient's defenses and what they can bear. And they will show you the lead about what they're able and ready to talk about. So it's really in the details of the relationship with the patient and the clinical session that you get a clue about today the day to try to talk about this. Yeah.
My question ultimately is about family work, but I just I want to go back years ago at Riggs, about maybe over 15 years ago. I treated a guy who was frankly psychotic, with elaborate delusions and hallucinations. Medications didn't do much for him, very little. They calmed him down just a little bit. He didn't want to take them, he drank. And he had a trauma as a child where he had an autoimmune disorder and lost all his hair. So he did not have a single hair in his body. He was a little boy. And it was very hard to follow the nature of the delusion, to work with them, to understand what they're about. But I remember thinking, this has got to have a meaning of a kind. And as the work unfolded, a year and a half later, he needed probably a 10-year treatment at the Australian Center to get anywhere. He had to leave. Something emerged about his father, where he began talking in a vague way about his father maybe having affairs, finding him in bars with another woman. It was very hard to know what's real and what's not. He would drink with his father. So my question to you is how do you think about family work? We were doing some family work, and it looked like we needed to do more to deepen things, but I wonder how you think about it and how you teach the rest of them about this, given what may be embedded in the family as stories you need the help of the family to elaborate and unpack, that my patient was having a very hard time, was partly because he was protective of them and was invested in keeping things obscure and not easy to get at.
We're really out of our time, so I'll answer very briefly. I admire people who are skilled at family work, and it's very important, but my intellectual path and my practice path has been somewhat different, through individual analysis and so forth. So I do individual work, not because I think that's the preeminent, kind of thing, but I occasionally will see a family, but I don't do formal family therapy. And I do some consulting online with families who are distraught about what's happening to their family member in the psychiatric system because they don't understand it. They don't know what's going on. They may have an intuition about what the problem is, and they get no validation from the psychiatrist that they have any understanding of what their family member is going through. So I don't do, formal family work. I admire it, and so got to have that on the team. So, all right, I think we need to stop. Yeah, okay.